All right, good afternoon, everybody. We'll go ahead and get started. Good afternoon. So I'm Silas Norton. I'm one of the nephrologists, but I'm also have the pleasure of being a counselor for our Alpha Omega Alpha chapter here at the University of Michigan. And one of the great things we have the opportunity to do is every year on the day that we are going to induct new student and faculty members into AOA, we also have the opportunity to ask our keynote speaker for the AOA induction to also be an internal medicine grad round. And so today, I'm really thrilled that we have the opportunity to hear from Dr. Paul Fine, who will deliver grad rounds today. And for those of you who don't know Dr. Fine is a clinical associate professor in internal medicine here. And Dr. Fine is really known and renowned as really being a fantastic clinician. You notice if you rotate with him, has received numerous recognitions for his clinical abilities, including but not limited to being one of our inaugural inductees in the Internal Medicine Clinical Excellence Society. And then more recently, he received the Medical School Lifetime Achievement Award in Clinical Care. In addition to his great clinical skills, Dr. Fine is really a terrific educator. He serves as one of our doctoring faculty, and similar to his clinical care, he's really received, I think, a number of accolades for his skill in teaching and educating. One that I'll just mention is the Galen's Silver Shovel Award for Outstanding Clinical Teaching, which Dr. Fine has won not once, not twice, but 3 times, which I believe is the only person to do that over the 8-year history of the program. And so, really thrilled to sit down Dr. Fine here this afternoon. He'll share with us some lessons he learned as a clinician educator.
Well, thank you very much. I really don't have anything to say. I just wanted to hear the introduction. So I'm going to come out in the audience and meet once with you, I think. So I am honored and really very humbled to have been asked to be the AOA visiting professor this year. I have to admit that the visiting part seems like a bit of a stretch because my office is 2 minutes from here. But I'm very grateful, nevertheless. You know, I've been on the faculty now for about 32 years, and when I started my career, it was pretty unusual to have the job title clinician educator. Most people had in their job description a research component, and it was rather unusual not to. Now that's no longer unusual, but I'm still a bit of an oddity because now I have a busy primary care practice and still attend inpatient general medicine several weeks out of every week. My goals for the talk, well, it's pretty simple. For the next 45 minutes or so, I'd like to share a little of what I believe I have learned over the years in these various roles as a medical educator, hospital physician, and as a primary care doctor. A little from each area. This will be scientifically light by design and more personal than most grad rounds. There may be some humor, because I'd like to have some fun along the way. And, importantly, I don't claim to have any exceptional insights or wisdom, but I am happy to share some of my own observations and conclusions. But first, the obligatory disclosure slide. I have no financial disclosures, but that alone would be boring, and so I will also tell you that I'm pathologically fond purple. This is well known. As a general internist, I can claim no expertise whatsoever. I find it hard to resist going overboard with distracting audiovisual effects. An unexpected disclosure, I've been unsuccessfully fighting a bad cold this week, and so I'm not sure if my voice will hold out. So if you like suspense, as you watch things, this will be suspenseful, and you see whether or not I can make it fully end reality. Here's the plan of attack, a quick outline of the subjects that I'd like to cover with you. First, some precepts for inpatient care, followed by some precepts for outpatient care. This is a little bit arbitrary because a lot of the precepts apply to both settings, and I just pick one or the other. Then some perspectives on clinical teaching, followed by a return to outpatient care, for a light-hearted proposal for making the patient portal less stressful. That's a bit of satire. And finally, a lyrical message for my patients. I'll mention here that my wife, my mother, and my sister are all here today, so please try to keep your heckling to a minimum. And to reward you for that restraint, here is your first cartoon. So we start with inpatient care. Now that I'm in my fourth decade as an inpatient attending, I've concluded that the longevity is a mixed blessing. There are disadvantages. I can't be sure that residents and students will understand my cultural references. I must guard against any tendency to start sentences with, well, back when I was a resident. And when I look in the mirror, I am forced to see the face that goes along with that much seniority. There are benefits. After more than 30 years, I know the location of almost every bathroom in the hospital. And more importantly, I can take advantage of the presumption that experience inevitably brings wisdom. This presumption, however questionable, allows most attending physicians to accumulate a series of clinical precepts to impart to residents and students. I'd like to share some of mine. Number one, expect to be surprised. Admissions take unforeseen twists and turns. We've all seen the new C. diff infection, the unexpectedly negative culture, the unexplained drop in hemoglobin, etc. I often ask my team to imagine writing out for each patient at the time of admission a rough outline of how the hospitalization will play out. Not the exact capacity on day number 5, just a rough outline. And then how often they think they'll be able to look back and say that they more or less nailed the prediction. No surprises. And although it might seem counterintuitive to lay people, the more experienced residents and I almost always offer a considerably lower estimate than do the interns and medical students. Number 2, don't treat outpatient issues with inpatient urgency. You know, there's a pace in inpatient medicine. We monitor patients continuously and we become accustomed to fine-tuning management throughout the day. But sometimes we fail our patients if we apply that same urgency to issues that are better addressed in the outpatient setting over months and years. One great example is hypertension. Studies show that we may worsen outcomes when we urgently treat moderate or even asymptomatic severe blood pressure elevations in the hospital setting. And in 2024, the American Heart Association recommended against treatment of asymptomatic BP elevations in most hospitalized patients and advised against intensifying BP medications at hospital admissions. Moreover, when it is appropriate in hospital settings to increase the dose of long-acting antihypertensive, we must remember that the soonest we would typically evaluate a change in the outpatient setting would be a week or 2. There's a temptation in the hospital, because of all the monitoring we do, to keep increasing the dose each day if the pressures are still high, even though the medicine hasn't yet achieved steady-state levels. Number 3, ignore the concerns of an experienced nurse at your own peril. Hospital nurses and medical professionals who spend the most time with patients typically develop great clinical instincts. In general, if a nurse is worried, we should be worried. Moreover, we owe nurses and other healthcare professionals, such as physical therapists, dietitians, aides, etc., our respect. We should ask for their input. And if we feel the need to interrupt their patient care, we should acknowledge the interruption and apologize. Number 4, common sense can lead you astray. It seems reasonable, does it not, to assume that anemic patients will always do better with normal hemoglobin levels. However, studies have shown this to be untrue, and we're forced to consider that the means by which we get there, transfusions or erythropoietin analogs, may have adverse consequences. Likewise, wouldn't common sense suggest that all patients will do better with the oxygen levels that healthy people have? But excess supplemental oxygen actually increases mortality among acutely ill hospitalized patients. So guidelines suggest a target SpO2 rate of 90 to 94% for most patients and 80 to 92% for those at risk for hypercapnic respiratory failure. And finally, as noted earlier, treatment to normalize blood pressure in the inpatient setting can be detrimental. There are many other examples of common sense leading us to conclusions that were later shown to be erroneous. Studies need to be done. Number 5, ask, can I afford to be wrong? This is my way of framing decision making when a patient is acutely ill or when particularly dangerous conditions are prompting on the differential diagnosis. If the answer is no, we may need to do things we otherwise try to avoid. such as ordering multiple tests simultaneously instead of sequentially, or starting treatment such as antibiotics or heparin before a diagnosis is confirmed. Of course, newer clinicians may be unsure how to answer this question, and it behooves them to consult with a more experienced physician or to err on the side of caution. In essence, acknowledging that they can't afford to be wrong about whether they can afford to be wrong. Number 6. Don't end rounds with your most complicated case. Clearly, unstable patients need to be seen first, but for the remainder, many of us like to group patients by location to reduce travel time and increase efficiency. But I try to avoid having to discuss the more complex or enigmatic cases towards the end of runs when we're no longer fresh and energetic. Number 7. Reframe your perspectives for discharge decisions. Perfectionists can make us want to delay discharges until every issue is fully resolved. However, this isn't practical. I ask myself, if this patient awoke at home this morning in exactly the same condition, I have recommended hospital admission. Likewise, sometimes we are anxious about a discharge because the patient has complex medical conditions and may not do well at home. In that situation, I ask, is there anything we can realistically accomplish that will make you less anxious about a discharge tomorrow or the next day? Or will I be just as concerned because this patient's status is inherently troubled? Number 8, 3 little words. People often make the mistake of thinking that the most meaningful and long-form phrase in the English language is, I love you. After all, Valentine's Day is only a week away. But hospital doctors know that it's actually no overnight events. Number 9, human interaction before medical interaction. Patients and their medical teams need to work through serious issues together, but usually start as strangers. Therefore, it is especially important to establish rapport quickly. I like to start with a non-medical topic, family, hobbies, a book on the bedside table, before moving on to the medical issues. I find this approach especially helpful when one will have to deal with potentially contentious issues such as pain management. But one must read the room carefully and determine if the medical circumstances permit this approach, and a patient is likely to accept it. Well, we're halfway through the precepts. Congratulations. So you've earned yourself another cartoon. You have to laugh at the cartoons because I don't know how long to linger on the cartoon until I hear all the laughter. Please go ahead and do that. We move on to number 10. What's routine for you is not routine for your patients. In medicine, we have the privilege of working with people during transformative moments of their lives, moments that are often among the most stressful and consequential they will ever have. However, routine mediated may seem to us, we must recognize that they are exceptional for our patients and act accordingly. 11. Patients generally appreciate people more than they appreciate your intellectual triumphs. Suppose we spend 20 minutes in a conference room dissecting a patient's complicated allergy disorder. We then go together to see that man who feels cold and sick and has trouble talking because his mouth is so dry. At that moment, he probably cares less about our brilliant explication of his physiology than he does about his discomfort. Shouldn't we, the medical team, take a minute and get him an extra blanket and a cup of water? Sure, he can signal for the nurse, but we're there. We can get to it immediately. He'll appreciate the gesture, and we will get to know at that moment that we made a difference, small little things. 12. Sleep is therapeutic. You know, we all want to be thorough, but sometimes it just seems kinder at 7 in the morning to allow patients to sleep and come back later. To justify this, I like to quote from literature that supports the therapeutic value of sleep. It's rather old literature, though, and I can see that it is not a randomized clinical trial. It's a passage from Shakespeare's Macbeth. In the play, Macbeth has murdered King Duncan, and his feelings of guilt prevent him from sleeping. He has a speech that lists a number of wonderful metaphors for sleep, including with a description of sleep as chief nourisher in life's feast. Team members then use this as a shorthand expression for the remainder of our time together, as in, I met Chester this morning. Number 13. It's a lot easier to tolerate diagnostic uncertainty when patients are improving than when they are getting worse. In other words, outcomes trump understanding. Number 14. Be wary of tunnel vision. When evaluating patients who have frequent exacerbations of a chronic illness, such as IBD, asthma, or sickle cell disease, avoid the assumption that the current presentation is just another flare. I always say to patients, you're the expert on your version of this condition. Does anything this time surprise you? 15. Unless a patient has a severe decompensation, such as DKA, severe CHF, don't give a diet in the hospital when a patient won't follow at home. We've all had patients who vigorously contest a diabetic diet or the restriction of sodium and fluid intake. We can reiterate the benefits of such dietary modifications as we see them. But save for the exception noted above, I don't see the advantage of enforcing dietary restrictions in the hospital if the patient doesn't plan to continue at home. The patient will be unhappy, and we will just be adjusting our medications to artificial circumstances instead of real ones. 16. Support a patient's supporters. When family members and friends have been particularly engaged and supportive, such as staying overnight, I believe it's important to let them know that their efforts have been noted and appreciated by the medical team. And we should be asking if there's anything we can do for them. 17. Sometimes optimal isn't available. We practice under constraints, including patient preferences, financial and insurance limitations, family support, community resources, housing availability and location, all of it. Sadly, we often can't implement what we view as the ideal plan. We have to learn to live with that. And one final precept that is implied by some of the others. Experience should bring humility. Over time, we learn that we should expect to be surprised, that there is going to be diagnostic uncertainty, and that we can't trust our common sense. We'll need the input of experienced nursing colleagues. And asking, can I afford to be wrong, obviously implies that we will sometimes be wrong. But even if we regret this lack of omniscience, we come to realize that effective medical care is always more about prioritizing the experiences and perspectives of our patients. Before we move on to the next section, here's another well-deserved cartoon for you. So now we turn to some precepts for outpatient care. Again, these apply also to inpatient. Number 1, not everything needs immediate action or investigation. If you're satisfied that a patient's symptom doesn't bring imminent danger, you can recommend monitoring it over time to see what direction it will go. Primary care doctors have a lot of conversations in which we ask someone how that quirky abdominal pain is doing, only to be told, oh, I forgot about that. They went away quite a while ago. Number 2, it probably means something when a patient who is always coming alone comes in one day with a family member or friend. That person is usually there to tell you something, or to make sure that your patient does. His or her participation has typically been negotiated in advance at home. In my experience, the most common issues brought up are memory loss, depressed mood, driving safety, or substance use disorder. If it hasn't already happened spontaneously, I'll often ask that person, is there anything you wanted to add? Number 3, normal test results don't always make patients happy. This may seem surprising, but we must remember that patients want to find an explanation in hopes that a successful treatment will follow. And in some cases, they are looking for objective validation to prove to others, sometimes including their physician, that their symptoms are real. Number 4, once you eliminate the impossible, whatever remains, no matter how improbable, must be the truth. I put this in quotes because here I'm quoting another physician, Arthur Conan Doyle, who put the words into the mouth of Sherlock Holmes. I believe this adage applies very well to a high percentage of the diagnostic mysteries that we encounter. And, just because I thought I just have to include this, Some practical advice to help patients get an earlier appointment in another clinic. I always make sure they have the clinic scheduling number and encourage them to call at 8:30 in the morning on any day that has snow on the ground or in the forecast. Sadly, this tends to work less well in August. And a reminder, common sense can lead you astray. This is worth emphasizing again. I don't want to belabor the point, so I'll just present one outpatient example. If elevated homocysteines are associated with a higher risk for heart disease, and folic acid supplements reduce them, it seems obvious that the supplements should reduce heart disease. But randomized trials prove that they don't. So now we get to move on to part 3, perspectives on clinical teaching. For this section, I'll sometimes use the term students to mean everybody in training. This could be medical students, but also residents and fellows. Now, I've been fortunate to have the opportunity to do a lot of teaching, for which I'm very, very grateful. Inpatient, outpatient, a lecture series for M2s on topics in internal medicine, the doctoring course, etc. And I thought I would share what I love about teaching. Now, let me present first the small picture, although I really don't think it's that small. The one-on-one or small group setting where one can interact, receive questions readily, and get a sense of whether light bulbs are being lit. Plus, I like the idea of taking someone who's in a potentially high-stress situation and trying to put that person at ease. What's the big picture? Well, I love the concept of helping to educate new doctors who will go on to teach others or to care for patients whom I will never meet, an ever-widening circle of eventual influence. Very idealistic. There are challenges, though, associated with teaching, and I'm going to put 2 of them on this slide. The first one is smartphones. I'm only half joking. There are 2 kinds of issues with smartphones. One is that they are a seductive distraction, as we all know. And the second one is that students can check you so readily now. I go back so far in my career, I hate to say this, that not only were there not smartphones, there was not internet. Okay? So if a student wanted to check on something that I had said, the person would have to go to the library and find it. I would be safely away by this time. Now, it's 20 seconds in the clock, so you really have to be on your toes. And the second challenge is keeping sufficiently up to date on advances in outpatient and inpatient medicine. There's always a lot of new research and guidelines that can be difficult to find time to review in a busy professional life. In other words, I need to ensure that I remain qualified. What would I designate as the most important traits for medical educators? There are many, but I'll list 3 of them here. First, when you are doing clinical work, availability. Since so much of the teaching comes through the supervision of patient care, knowledge is easier to come by than previously. See the smartphone on the previous slide. But the reassurance of a more senior clinician's experience still means a lot. Yes, the ability to remember what it is like not to know that which one has known for years, so that conceptual structure can be built from that perspective. This can be challenging. It's one reason why, as I will get to later, experts are not necessarily more effective teachers. And it also applies to clinicians, of course, who need to be able to adopt this mindset to teach their patients. To explore this further, let's look at a scheme that I find valuable, the 4 stages of competence. Nicely depicted here in this pyramid. And we'll define the stages together and apply them to learning how to drive a car. We start at the bottom with unconscious incompetence. A person does not understand or know how to do something and does not necessarily recognize the deficit. We don't know what we don't know. A young child may think that driving a car only involves a steering wheel. Well, a little later, we start to learn what we don't know. A 15-year-old starting to take driving lessons begins to realize how much there is to master, but can't do it yet. This is conscious incompetence. Well, for the state of conscious competence, the individual now understands and knows how to do something, but there's a heavy conscious involvement in executing the new skill. And this requires continuous concentration. This is someone who has just passed his or her driver's exam. And finally, one gets to the point of unconscious competence, where there's been so much practice with the skill that it has become second nature and can be performed easily. As a result, the skill can be performed while executing another task. Somebody can drive and have a conversation with the passenger while doing so, or may complete a drive without remembering any of the details. So getting back now to teaching and applying this, I believe that the best teachers know how to get themselves from unconscious competence back in the mindset of conscious competence, so they can guide learners in getting to that very same level. And the third important trait of medical educators, having a greater interest in the student's experience than in your own. You know, we all have topics we enjoy talking about, or things we research, or things we believe we have a knack for explaining well. But that shouldn't be the focus. Instead, concentrate on making sure that the topics discussed are important for learners to know, that they don't already know them, and that you are succeeding in teaching them. In other words, don't choose topics just because you happen to enjoy talking about them. Ask yourself, are my students getting as much out of this as I am? What is not an important trait for a medical educator? A threatening. This is me on the poster of the 2019 Daily Smoker after I was asked to look intimidating, which did not come easily for me. Now let's turn our attention to some educational precepts. I managed to come up with about 25 of these, but good news for you. For today, I've cut the number almost in half to 14. Number one, you don't have to be an expert to be an effective teacher. Students and residents often hesitate to teach because they think they don't have enough content expertise. But non-experts might actually be more effective teachers than an expert, as they can remember what it's like not to know. Or putting it another way, they may more readily get themselves back into the mindset of conscious competence. An example has nothing to do with medicine. This is my grandmother. She was a wonderful maker of blintzes, and she decided one time to teach my wife Karen how to make blintzes. Well, she was an expert, but she struggled to teach because she kept trying just to communicate the intuition of unconscious competence, her level. She would say things like, just keep adding flour until you get to the right consistency. Make sure you're happy with the balance of spices. Take it out of the oven when it looks done. Nothing that Karen could operationalize to know how to do this task. And for this reason, I've been the product of blintzes for 25 years. And not happy about it. Another interesting thing about my grandmother, I might mention, like my mom, who's here today, she was one of the older women who looked much younger than she was. For example, she was 83 when this photograph was taken. I always assumed that she was pleased with this, but here's what she told me when I asked her. No, dear, I don't like it when people think I look younger than I am. If they do that, they will underestimate the degree to which I suffer. That was Grandma in a nutshell. In summary, teaching skills and subject expertise are different. It's great to have both, but the former may well be more important for education is concerned. Now, I acknowledge that this point may seem a little self-serving because I consider myself an example of someone who's a reasonably effective teacher, but as I mentioned at the start, not really an expert at anything. Precept number 2, don't be afraid to say, I don't know. It will not undermine confidence. Students don't expect admissions. In fact, it may generate more confidence in the answers you do give. But vow to find out and follow up. I keep a note card in my pocket, and I write down these assignments for myself, so I can get back to the student. However, as a public service, I will tell you that should you feel the need to avoid saying, I don't know, there are some proven techniques. Number 1, turn the question around on the person who dared to ask it. I could answer that for you, but you'll remember it better if you look it up yourself. Please give us a 5-minute report tomorrow. Number 2, shake your head ruefully and say, it's mired in controversy. After all, what isn't controversial these days? Dr. Monroe would tell you, you can't get 8 out of 10 nephrologists to agree that creatinine has something to do with renal function. And number 3, look at your watch and say, regretfully, I don't have time to go into the details now, but let's just say it involves cytokines. Number 3, always make clear the difference between this is how we do it, and this is how I do it. In other words, differentiate between those things that are more or less universally accepted as standard views and practices, And those things that are really just our own preferences. A non-clinical example for me is patient presentations. I don't like the use of the term the patient, as in the patient reports knee pain. I prefer names and pronouns, as a reminder that we are talking about an actual person. I know most attendings feel differently, so I always present my rationale and encourage learners to decide for themselves. Number 4, monitor to determine when people need a brief handshake. You know, sometimes you look at people and you can just tell they are at mile 18 in a marathon. Eyes glazing over. They may need 1 to 2 minutes just to reset. For example, you might conduct an impromptu survey of favorite pizza toppings or Doritos flavors. And of course, since you are the teacher, you get to provide the correct answers. For pizza, it's green olives, and for Doritos, it's taco flavor. Not well known, worth checking out. Number 5, seek feedback and take it seriously. There are always ways in which we can improve. For example, after I give a talk and have a sense of what worked well and what didn't, I sit down as soon as I can, while fresh in my mind, and make notes about what to change for next time. If I can't often record a presentation, since I often didn't do as well as I remembered doing, if one has a trusted mentor, it can be helpful to have that individual observe the teaching or to watch the recording. I read the feedback that I get from medical students to see if there's something there that I can use to improve. One thing I found out is that I tend to speak too quickly. And so I've been trying to modify that, but I can't. And finally, I ask students halfway through and at the end of a rotation how things have been for them and what we can do to make it a better experience. Obviously, one has to make it clear that one really wants a candid, honest answer. And hopefully by that time, you have enough of a good relationship established that students will believe you and not fear any repercussion. I will comment more here on giving feedback as we get a lot of excellent guidance on that. I will say that one should not follow the example set by my first grade teacher, Ms. Blueville, who my mom's already started to laugh, who had a parent-teacher conference with my parents when I was in first grade, and said, and I quote, "Paul will never amount to anything. And if he were my son, I would go home and cry." Yes. Number 6, change things up by having creative ways to teach. Have fun with it. Go a little crazy. 4 humble examples to follow. This some of you may recognize as Jim Valvano. Jim Valvano was the storied coach of the North Carolina State's basketball program, and he won an underdog national championship against Houston, and he was a very life character. Unfortunately, he later developed metastatic adenocarcinoma of unknown primary. And I was reading one day one of my very favorite medical journals, Sports Illustrated, and Gary Smith, a wonderful writer, had a profound article on Jim Valvano and his experiences as a cancer patient, which put it so much better than I could ever have hoped to. It was just fantastic. And I knew I couldn't do any better than that, so when we had a patient on our service at the VA hospital at that time who had this diagnosis, I just brought in the article and read much of it to my team. And I had a case to learn recently that Sandro Sinti, who, believe it or not, was my intern on that service, still remembers the article and the powerful message that it provided. This is the code blues. I decided many, many years ago that it would be fun to try to put all the ACLS algorithms into a song. So I wrote down all the words and all the music, and it was going to be all the details, the exact medications in the proper order, the doses, everything. I was very happy with this. And my goal, of course, was to hear the code pager go off and to see residents sprinting down the hall to the code, singing my song to themselves to prepare for writing the code. Well, almost immediately after I finished the song, all the algorithms changed. And I was just in despair, and I never had the heart to go back and do it another time. And so I had to give up the entire thing, including my favorite rhyme, which was, "There's no need to despair at all, just try isoproterenol." Sometimes it's fun to call up YouTube videos of medical shows, talk about them, comment on the clinical care, comment on the patient interactions, something like that. I use ER. a lot for this. There are 20 seasons, I think, of ER, so there's a lot of material. And the latest silliness is an animated video on acid-base disorders, where the soundtrack is entirely in rhyme verse. This came, it may not surprise you, from the pandemic. Things were weird, so I decided to do something weird, which is to see if I could write an entire acid-base lecture in the form of a poem. Now, there's no demand for such a thing. It's very, very strange, but I wanted to see if I could do it. And then I found some undergrads at U of M who are way more capable than I could ever be at graphics, and they put graphics with it for me. And now we get a little video. And I don't teach from this, I do it the old-fashioned way, but I do give people a link if they want to sort of using refresher and how it works. So those are a few creative ways that I've found over the years. Number 7 and 8. In clinical work, you're often going to have to teach times when it's inconvenient and you're hurt. It can't be an excuse. However, you're teaching even when you're not teaching. In other words, you teach not just with what you say, but with what you demonstrate. For example, interactions with patients, so-called bedside manner. What I mentioned in the first section, getting water or blankets or other tangible means of demonstrating to patients that we care about them. And it makes more of an impression on learners if you do it yourself, even if you're in attendance. Because kindness need not be processed through a hierarchy. We can show interactions with nurses, how to process the frustration with so-called difficult patients or family members, demonstrating how to research a clinical question on the fly, on the smartphone, and how to process the feelings we have when a patient dies or goes to the ICU. Number 9, emphasize clinical decision making explicitly. Why? Because there's so much nuance, and because it's something students and residents can't find on their smartphones. In fact, as information and practice guidelines continue to get more and more quickly accessible, contextual decision-making may become more and more what we need to be demonstrating. And where there's clinical decision-making, there are decisions, and therefore an opportunity to pull in everybody on the team. I like to frame a clinical question and the options, and then go around and have everyone state, commit to what they would choose to do, starting with the least experience and working upwards. This keeps everybody involved, even the people who are not following the patient themselves, and makes the subsequent course more interesting and educational, since everyone will be more invested in learning how things turn out. And speaking of finding out how things turn out, find out how the story ends. Clinical learning will be enhanced if a team member takes responsibility for finding out how the story ends and sharing that information with the rest of the group. For example, how did the biopsy or a follow-up scan turn out? How does the patient feel a few days after a hospital discharge? What was the specialist's opinion at the follow-up clinic visit? 11. Try to translate for the uninitiated. In clinical settings, try to monitor the conversation to see if there are quick explanations or definitions you can give to allow the less experienced learners to follow along. They are likely to be reluctant to interrupt with a question, but sometimes just knowing what an acronym stands for can open the door to understanding. 12. Be realistic when sharing medical literature. It's great to review studies together, or to assign a paper with plans to review it together later. But just handing out or emailing research papers every day to people who have little time to read them may just be a way of saying, here, have some guilt. 13. Customize your approach. The best doctors, as you know, their approach patient to patient and develop the ability to read people quickly, to try to offer to each patient an individualized approach. The same applies to teaching. Assess each student's needs and get a sense of what teaching style will work best. More questions versus fewer. How often to assign independent research or presentations. When to move on to the next concept. And how much non-medical conversation or lightheartedness to put a student at ease. And one final precept, perhaps the most important. Think back to your own training, no matter how long ago it was, and be the kind of teacher you always wanted for yourself. And I'll add, if you'd say yes to a request, just take the initiative and offer to write a letter of recommendation, so that the more reticent students or residents don't have to endure the awkwardness of having to ask you. Another cartoon, this one about my own teaching. Well, in the end, hang in there, we return to outpatient care and a lighthearted proposal for making the patient portal less stressful. I'm going to have more to say later about the wonderful aspects of outpatient care, but I want to talk to you first, tongue entirely in cheek, about a healthcare crisis among physicians that has been precipitated by the growing demands of the patient portal. And, spoiler alert, I do have a solution to propose. While it's undoubtedly true that the portal has enhanced doctor-patient communication and led to some important improvements in care, anecdotal experience suggests that high message volume is having a deleterious effect on doctors' blood pressure. I have dubbed this phenomenon portal hypertension. Unsurprisingly, there have been objections from linguistically territorial hepatologists. Surprisingly, this new form of portal hypertension has not yet been confirmed by a randomized trial, even though thousands of doctors across the country have volunteered to participate, each hoping to be randomized to a placebo group. Though the pathophysiologic basis for this new form of secondary hypertension has yet to be fully elucidated, experts hypothesize that it is multifactorial. One cause is believed to be lack of sleep, as doctors stay up later trying to clear their electronic in-basket before the following workday. Another is an increase in daily sodium intake, as they consume bag after bag of Doritos and potato chips during those evening hours, a phenomenon formerly known to psychologists as the "I may still be working, but at least I'm snacking" rationalization. Decreased time for exercise likely plays a role. And of course, there's the surge in catecholamine and cortisol release that occurs when they click refresh after handling a message, hoping for the satisfaction of seeing a decrease in the number of remaining messages, but find instead that 2 more, like head to the hydro, have already replaced it. How best to treat this hypertension? Well, one could employ the usual antihypertensive medications, but this strategy has several disadvantages. Cost, side effects, and a difficulty in quickly clearing them from the blood for those occasional days on which a physician manages to be free of all patient care responsibilities. The preferred strategy must therefore involve changes in the electronic in-basket itself, with antihypertensive strategies that adjust automatically to the level of work on a given day. I would like to propose several such modifications. Number 1, random, joyous surprises. For every 5 authentic messages, there will be a 6th that looks real, but is actually a designated smile generator. Doctors will be able to customize this feature. One of them might open such a message and see photos of children or grandchildren, while others might choose to see videos of cute kittens or your favorite song. Number 2, proof that one is making a difference. Too often, we doctors spend our clinical time simply massaging outcome probabilities, without knowing for sure that a particular intervention has helped a given patient. Certainly, statin therapy, colon cancer screening, optimal glucose control, vaccination, these have all been shown to help the population. But it would be great for physician morale to get verification that a particular patient received benefit. Therefore, the inbox should provide notification of adverse outcomes that would have occurred but for clinical intervention. For example, on October the 12th, a doctor might get this message. Today is the day that your patient's pernicious workload would have had an MI had he not been given atorvastatin therapy and the wonderful control of his blood pressure and diabetes. On November 5th, another message might come. Well done. Today is the day that Marmella Microwave would have been diagnosed with lung cancer were it not for your assistance with their smoking cessation 20 years ago. This information would also be shared with patients, of course. Imagine how much more motivated they would be to act on doctor's recommendation when given this confirmation of benefit. Now, I acknowledge that there are a few thorny technical obstacles to overcome before this alternate outcome notification can be implemented. I am counting on the talents of the EMR program. They can use some of the hundreds of hours they would otherwise spend deciding whether to move the patient's medication list from the left side of the screen to the right. Number 3, encouraging advanced planning. Mail order pharmacy prescription renewals should be requested 1 week in advance to make sure that the medication arrives before the current supply is exhausted. If a patient forgets to ask in time and requests that a 7-day supply also be sent to a local pharmacy, the system will accommodate that request the first 3 times. After all, we want to be patient and kind. But if it happens again subsequently, some tough love will kick in, and the system will issue only a 1-day supply with 6 refills. Number 4, honest triage. A physician's blood pressure often spikes in response to truly urgent clinical situations, but it can also increase in response to non-urgent portal messages that are mislabeled as urgent or high priority. The portal will therefore automatically reclassify as routine any message that includes one of the following phrases. A friendly one that I read on the internet. Toenail funny. And forgot to mention at all. Number 5, elimination of bad news bias. Understandably, patients tend to write messages when there's a problem with which they need help, not when things are going well. But the delivery of a relentless stream of problems and concerns can be problematic for the physicians, but need to be some good news from time to time. Therefore, 15% of portal messages should be designated for this purpose. For example, just some gratitude. Hi, Dr. Fine, Harrison Grubler here. I was just thinking about how great I feel and what a wonderful day I am having. I sure do appreciate how much you have done to make this possible. I know you're busy, so no need to respond. Number 6, message diversity. It seems reasonable to assume that portal hypertension would be reduced if messages were communicated in a more entertaining way. Therefore, any patient who has already sent a message within the previous week will be required to compose the next message in verse. Doctors will be able to specify a favorite poetic style. For example, some might find Dr. Seuss most appropriate. Dear doctor, I'm sending a message to say I have a strange symptom that's causing this night. My uvula aches when I'm sending a text. The doctors at Mayo were very perplexed. I'm leaving tomorrow for 3 months away, so I hope we'll be able to cure this today. Others might prefer a haiku. My uvula throb, only with text. Mayo stomach, help by tomorrow. And finally, form reform. Completion of submitted forms is one of the more time-consuming and hypertension-inducing tasks that doctors are asked to do. I propose that each form should prompt an immediate assessment of the physician's blood pressure by an automated cuff connected to the computer. And if the reading exceeds a certain level, completion of the form will be deemed too dangerous and required. For a 1-page form, that level will be 140 over 80. For forms that are 2 pages in length, it will be 120 over 70. For forms with 3 pages or more, it will be 70. Ultimately, protecting the health of our patients requires protecting the health of their doctors. I believe that prompt implementation of these proposals will reduce the incidence of physicians' portal hypertension and its attendant complications, cardiovascular disease, and chronic irritability. We've known for decades that doctors should screen patients for hypertension, and now need to prevent screen-induced hypertension among physicians as well. And before we move to the last section of the talk, another cartoon. Some of you may know that I will be transitioning away from my primary care practice in July, though I'll continue to round on the inpatient service and do all my usual teaching. I can't adequately put into words what being a primary care doctor has meant to me. I'm an idealist and proud of what we all do. But whenever it feels as if my idealism might be threatened by some of the more frustrating aspects of the job, I focus my attention on the wonderful and meaningful relationships that I have with my patients. I'm going to say more about what I call relationship-based medicine tonight at the airway induction banquet. But I'll say now that though frustration and burnout are very legitimate and concerning issues, I have found that focusing on the relationships has helped me a lot. Some of you may remember Denny Schauber, who was the residency program director when I was a resident, and in my early years on faculty. A wonderful man. When he left UVM, he gave a final grand rounds in this very auditorium on his research interests in infectious disease. At the conclusion, he said, "And now, I'd like to end with the accomplishment of which I am most proud." And then showed, without additional comment, slide after slide listing the graduating residents from each year of his tenure as program director. It was powerful and poignant. On my next slide, I have listed in a font intentionally too small to be read, a list of my current primary care patients, representing many others who have moved on or are no longer with us. I'm a sentimental man. The prospect of leaving behind my outpatient practice is very difficult for me. I believe I've done something important for my patients, but I know they have done something important for me. So I decided to present them with a somewhat sappy song of thanks. Nobody who knows me well is surprised by this. If you'll indulge me, I'd like to close today by sharing the lyrics with you. Hokey though they are, as they sum up a lot of what outpatient practice has meant to me and to so many of us. And because it feels right to offer a public tribute to this great group of people, even if I can't identify them individually, and most of them are not here. Why just the lyrics? Well, I could say that because I don't have a piano here, or that the answer is mired in controversy and involves cytokines. But the real reason is that exposing you to my singing voice, especially today, would violate first do no harm. As my time as your doctor now comes to a close, a sentiment grows. And there's a message I want to say clearly. I mean it sincerely. Thanks for your confidence. Thanks for the trust. For all the non-medical things we discussed. Thanks for the laughter. Thanks even for tears. The affection you gave to me over the years. We've grown older together throughout my career, as my mirror makes clear. There's a comfort that comes as the decades go by, an enduring supply. Thanks for purple you've chosen and put on display, for the purpose you gave to my work every day. But thanks most of all for truth that transcends. You came in as patients, but now feel like friends. You came in the mornings to Taubman 3D to visit with me. You did something special that merits remarking. You put up with the parking. Thanks for your kindness. The gift you bestowed to take me along as you traveled your road. My time as your doctor has been very well spent. So I'll end with a promise I want to present. Just 10 little words to convey my intent. I will never forget you and all that you've meant.
Thank you. Delighted to see that your voice made it through.
Thank you.
And we appreciate you sharing some of your wisdom with us today. And of course, we also thank you for those practical tips on in-basket management that everyone, so we'll get working on
Good.
that.
I'll do it too.
We have time for questions or comments from the audience.
I predicted that there would be questions.
Well, Paul, I think I must be one of the 10,000 faculty who have been your patients. And we've loved being your patient, and we so much appreciate it. And you're wonderful, and I'm happy you're going to still be around, rounding and doing other important things. So thank you.
Thank you.
Hi. Today is my last day on service. You kick off my service tomorrow. So I'm just going to ask how you like to sign out, but I have to. In verse, I know I'm terrified. But I noticed something that is a you thing that I didn't connect in my head until I saw your talk. So that felt very meaningful. And then there were other just points of your talk that I realized have transcended the years in my own practice. And I just sort of want to share the joy of being able to see that come full cycle, to be able to hand you a service that I hope you'll find remnants of your own teaching embedded in that.
Thank you, that's wonderful. I really appreciate that.
Thank you so much, really wonderful.
Thank you.